Good afternoon, everyone. At the outset, I thank the scientific committee of IPC for giving us a chance to talk on approach to group pancreatitis. My talk will be a sensitization for the trainees about group pancreatitis and the step-up therapy for the management of group pancreatitis that we published earlier this year. As my boss always starts his presentation, I would want to start with a story of Mr. Parnivel, a 51-year-old male. He used to have alcohol about 180 ml of Indian-made foreign liquor about thrice a week. Coming to us with features of gastric outlet obstruction with recurrent vomiting and weight loss of 8 kilograms. And he has had recurrent pancreatic episodes of pancreatic abdominal pain for the past 2 years, which gets better with oral analgesics about within 1 hour. So we have come to the gastroscopy was done to look for the feature of gastric outlet obstruction, which showed duodenal narrowing, and CT, which showed a lot of inflammation around the pancreatic head with duodenal inflammation and narrowing. The questions that arise is: what are the differential diagnoses? What are the investigations to reach a diagnosis? How to differentiate between group pancreatitis and malignancy, and how to manage the disease. The group pancreatitis is actually a wild card entry in this acute pancreatitis group because it's a form of chronic pancreatitis affecting the pancreatic duodenal groove, predominantly involving the middle-aged males with history of alcohol and smoking, who presents with gastric outlet obstruction and pancreatic pain. This is our data which we published this year. About 50 out of the 50 patients that we followed up, 96% of them had abdominal pain and about 90% had significant loss of weight. And if you see the anatomy, there are mainly two types of group pancreatitis. One, a pure form in which only the groove is involved, and a segmental form where the inflammation actually spills over into the pancreatic head. And this is the form which actually we have to actually differentiate from a pancreatic head malignancy. The etiology is multiple factors, multiple etiological have been proposed, out of which anatomical or the functional obstruction of the minor papilla is the main etiological factor which has been proposed. Developmental variations of the PD and many associations with peptic ulcer disease, biliary diseases, and history of gastrectomy are all thought about. But if you see the microscope, it's all most of them had Brunner's gland hyperplasia only. And some of them had granulation tissue with foreign body giant cell reaction. But whatever it said, there are thickened duodenal walls and fibrous and inflammatory changes in the pancreatic duodenal groove. Lab diagnosis, biochemistry is of no use, I would say, because alkaline phosphatase and serum bilirubin will be high only in those patients who have an obstruction or biliary obstruction. Amylase lipases will be high only if there is active inflammation going on, and CE and CA99 at this point of time we cannot use it to differentiate between group pancreatitis and carcinoma. The mainstay of diagnosis is radiology, where you look for the groove, where you look for the duodenal wall, you look for the pancreatic parenchyma and associated changes. In the groove, you actually see the loss of fat plane between the pancreatic head and duodenal wall if it's a segmental type of group pancreatitis. There are sheet-like masses in the groove and fat standing. In the duodenal wall, there are cystic changes, which is very sensitive, and eccentric wall thickenings in the duodenal wall. The pancreatic parenchyma will have some inflammation and some narrowing of the PD. Associated changes like banana-shaped gallbladder, grossly dilated gallbladder, and smooth tapering of the CBD are all features. How will I run this? How will I play the slide? Yep. So the CT shows not very much the thinned out pancreatic parenchyma, but dilated NPD, which is tapering at the lower end, and this is much more clear. We have the dilated MPD, and then it is slowly tapering. We have a gallbladder which is quite dilated. This is the CMC data in which the radiology we said that medial wall thickening is found in almost 100%. And enhancement of the scar tissue in the groove. How to differentiate it from pancreatic head cancer? If there are cystic changes in the region of the accessory duct, the minor duct, you are more likely to be group pancreatitis. And there can be focal thickening and abdominal enhancement of the second part of duodenum. And if there are no vessel involvement, it is more likely GRU than a pancreatic cancer. Role of endoscopic ultrasound, you actually can see all the things that we have seen in a MRCP or in a CT, like the disease extent, the thickenings in the D2, the cystic changes in the wall, the enlarged pancreatic head. But the extra thing that you can get is a biopsy by using an EUS-FNA or FNB, which can add to your armamentarium. The management is of mainly three types. One, reduction in pain episodes, improve nutrition because of the gastric outlet obstruction, and management of complications. So we would want to propose step-up therapy in treatment of group pancreatitis to start with conservative management, then followed by endoscopic treatment if not getting better, and then surgical management. The majority of the literature is basically from surgical fields where they go out into the as a first line management, surgery as a first line management of group pancreatitis, which is slowly changing. The conservative management consists of healthy, balanced diet, pancreatic rest, probably by a nasogeneal tube, analgesics, and abstinence from alcohol and smoking. This data is actually for chronic pancreatitis. Does abstinence of alcohol and smoking affect group pancreatitis? Yes. If you stop smoking and alcohol, the pancreatic quality of life, the BMI, the narcotic use, and the HAT score are all better. Roopjyoti sir has published this in pain management in chronic pancreatitis. Both antioxidant with pregabalin is much better than placebo alone. If you see the medical management of chronic pancreatitis for pain, PERT is of no use, but antioxidant, yes. Neuromodulators, yes. If you combined, yes. Endoscopic treatment. So the second step is endoscopic treatment. If the patient does not get better, then go for endoscopic treatment. Deep enteral feeds gives pancreatic rest, and it will also give nutrition in duodenal stenosis. If you have distal biliary strictures and an abnormal LFT, not just alphas being elevated, but with bilirubin, higher bilirubin, then you can think about ERCP and stent placement. EUS procedures, basically, as I told you, for biopsy. Cystoduodenostomy, of course, if there is a cyst which is compressing which causing local complications. Celiac plexus block if the pain is not getting better with medical management, or a gastroenterostomy if the gastric outlet obstruction is not getting better. I know this is not an endoscopy conference, so we'll just skip the celiac plexus block part. What is this evidence of EUS-GJ in benign GU? It is actually picking up. These are there are two papers from 2018 and 2019, 2018 and 24, which said that EUS-GJ can be used in benign gastric outlet obstruction. We'll skip this video also of EUS-guided gastroenterostomy. Evidence is getting better. This has come very recently in about 87 patients for benign indications, and I think EUS-GJ is the way to go. This is the flowchart that we had found, that we had put up in the paper. We had about 50 patients, out of which we followed up 35. Most of the 22 patients responded to conservative management alone. Those patients who did not have response, if there is a biliary obstruction, we went ahead with ERCP, and but both of them didn't get better, so they had to go for a hepatogoginostomy. Those patients who were symptomatic with abdominal pain, they were given deep enteral feeding and gastric outlet obstruction, out of which 6 of them got better. Those who did not get better, 3 of them were there, whom we gave we had to go for a gastrojejunostomy. And for the pain part, 2 of them, one of them responded to celiac plexus block, but one of them had to be sent for a surgical procedure, and 80% of them responded to conservative management in our cohort of patients with group pancreatitis. So gastric outlet obstruction, trial of deep ventral feeding, if not getting better, to go ahead with GJ, and biliary obstruction, ERCP, and still not getting better, to go ahead with hepatogoginostomy. This is a systematic review of group pancreatitis published in 2023. A very small number of patients were treated with conservative, then followed by endoscopic, and then surgery, which will change in the future, I believe. So prognosis of group pancreatitis, we propose a step-up therapy for the management of group pancreatitis, and we think that it's quite reasonable. And conservative therapy is the way to go to start with, followed by endoscopic and surgery if not responding. Healthy balanced diet, pancreatic rest, and abstain from alcohol and smoking can prevent recurrences in the future. Thank you.